Finance Committee and our regular board meetings. Each one of you have a microphone in front of you. To keep the background noise down, please turn your mic on and off when you are recognized to speak. Anyone who will be presenting will be asked to go to the podium and use the microphone. All meetings information is posted on our media sites, and so again, this will be placed on Channel 3 and on the YouTube channel. So we were previously using Facebook, I believe, and so this is just a cleaner process in terms of what we present. So we're going to ask if representative from the Metro News Network will give us instructions on how to use this fancy equipment.
Hi guys, my name is John. I work for Metro National Network. Thank you guys for inviting us. We're happy to do it. On each of your microphone channels, there are two buttons. The button on the right is the button.
Thank you. And with this equipment, when you turn your microphone off, the camera will zoom in on you. So we get to also see everyone's wonderful face. So our conflict of interest, this is an opportunity for each member to disclose potential conflicts and their belief that they can be unbiased and unable to participate, or they elect to recuse themselves from the matter. You have that opportunity at this time. And the mission statement is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating service into clinical practice. Before we go into public comment, I want to pause here and ask Dr. Webb if he will present special recognition at this time.
All right, am I live? I want to call attention to our 2023 Employee Wellness Program participants. Our strategic goal here is the triple aim, and the quadruple aspect of the triple aim is caring for the caregiver. So in caring for the caregiver, it's also one of our strategic pillars: people, service, quality, and stewardship. So in keeping with that, we have a program that we started a year ago, and it's led by Tiffany Kelly, who has done a great job. This is the second year of the Wellness Champion Program, and we had 52 employees spanning 23 departments participating. There was 400, and it's wellness now, there were 458 total pounds lost. 20% increase in participation from 2022, 30% increase in weight loss from 2022. So please congratulate our 2023 Wellness Champion. She's here, Miss Janetta Hastings. And our trainer, Tiffany. So you guys want to say anything?
I would like to say a few things. Do you want me to go there? Please.
Yeah. She came ready.
Coverage of our program that we've had. We had the 2022 program and the 2023 program, and we have 109 people signed up for the 2024 program, so we continue to grow. What I'd like to say about Jonetta is she encompasses Wellness Champion, not just because she signed up for the program and committed. The program our participants commit to exercising at least 3 days a week with an elevated heart rate for 30 minutes. They also commit to watching our wellness videos. Most of those are done by our dietitians to give ideas for grocery store tips, nutrition label reading, things like that. So they have help not only in the exercise standpoint, but also in the nutrition standpoint. So Jonetta came to us last year, and all of her biometrics were in high risk ranges. Jonetta has done an absolutely astonishing job. At the end of the year, it's just been 1 year that Jonetta's been with us. She is now in optimal biometric ranges in every unit of measure. So that is huge. You guys, that is very, very hard to do. I'm just so amazed, and she's talked to me a lot about how, it's a group effort, and she has a teammate that she works with, a buddy that they encourage one another. It works very well, and it is successful to have that buddy as an encourager. So that is our program. We look forward to continuing to grow, and we had actually four female winners this year. Jonetta was the wellness champion, but there were also 3 other ladies who lost their biometrics greatly improved as well. So we had a lot of improvement this year.
Let me give the names of those 3 individuals.
Yes.
Linda Stills, Sherry Olivares, and Tracy Benton.
Yes.
Those were the 3
Yeah.
runner-ups.
So thank you guys for supporting the wellness program.
And thank you all. We appreciate you showing up and sharing that information with us.
Yes, thank you. All right, do we have any public comments? Okay. So we now will move to approval of our minutes. You've had a chance to review those. Are there any corrections or additions to the minutes? None. If not, then I'll entertain a motion to approve the minutes.
Second.
Thank you. Moved and proper second. All in favor, vote by the sign of aye. All opposed, ayes have it. Minutes have been adopted. All right, we'll go into our old business revenue discussions. Bruce, you're recognized. Yes, absolutely.
That's okay. I suspect Dr. Brown can probably give us a little bit of an update, but I do know that we've gotten a contract in place with CoreCivic, I'm sorry. We got a contract in place with CoreCivic that's just kicked off, and we're very close. I don't think I have the signed one back on the TDOC folks yet. Okay. Those are the 2 primary ones that we've been working on. We have the physicians available. We have the services available. We just need to have a contract, and we have rates that have been offered, and I don't think are at issue. So, and not only will it get us coverage for the day that the physician is out at the site, but it'll bring downstream, obviously, when they find pathology and have to bring those patients into the hospital for services or surgery. So positive, we're making progress, but it's not us holding it up.
One thing is that we actually have patients. So let me remind you, we need a mic.
Dr. Webb signed that contract a week and a half ago with CoreCivic, and so we have those patients on the book and set them up for telemedicine already. So those are already on the schedule. So as the months go along, we should start seeing downstream revenue from those patients from CoreCivic that need to have services here at the hospital. We've already set up TDOC, TDOC, and Centurion, and so we've been out there. We're just increasing our presence out there on that campus. And so the next phase of TDOC is to start doing procedures there. out there on the campus as much as we can. We're pulling the team together. We met last week, a team of us, to talk about going out and visiting. So we have a scheduled visit for the team to go out to actually look at the facilities, our infection preventionist, our OR manager, and a couple other members to go look at the site to see what we need to do to bring it in compliance with Joint Commission. And then once we do that, then we should start moving forward on doing procedures out there. There's a couple of providers that are also going with us so they can look at the space and determine what they can and cannot do out at that facility. That's the update that we have.
Thank you. Any questions or comments? All right, hospital utilization, Ms. Poole.
There we go. I need to start sitting down at this side, I suppose. So this is really specific toward the Metro Healthcare Incentive Program. So this last month, October, our utilization was up a full 1% from 5.8% to 6.8%. We also had the Mammos for Metro program. So right now I have a total number of mammograms, screening and diagnostic mammograms that we did for October, but I had asked them to break out how many Metro ones, just so we can at least be able to track and compare the difference based on the outreach that we did to the Metro departments versus who just kind of might have already had to have a mammogram, because annually you get it done typically in the same month. And then we, with the new diagnostic center in Bordeaux that we're opening up, we look to bring back our Mammograms in May program. So that is the Mother's Day gift that saves lives, started probably over 15 years ago. And it just sets us apart from the typical October mammogram month and helps increase the number of screening mammograms within the community. And it's going to be very important for Metro because of the new change in insurance that Metro has. So we look forward to starting that back up as well.
Thank you. All right, we'll move to Bordeaux Clinic update.
So last week, or earlier part of this week, they started installing the imaging equipment. So the CT scanner, the MR scanner, the X-ray equipment have all gone in this week. The second floor is completely finished out other than just signage on the walls. We're expecting delivery, I think the 6th and the 7th for our exam tables, or what we call white glove initiative, where they bring in and set up, and then we'll have a final cleaning. We're expecting that clinic to be turned over to us on December the 14th or 15th. So right now everything is on track, and we're excited to get the equipment in, because that's one of the bigger things that we had to get done in order to get that open up for the imaging center. Happy to answer any questions.
Thank you. Glad to hear that that's moving along. All right, Dr. Webb, recognized for relocation updates.
Yes, my office is in contact with the mayor's office. We're working on getting a date scheduled to meet with him to go into discussions regarding location for the new hospital.
All right, any questions around that? We'll move into new business. Dr. Brown, you're recognized again for emergency code plain language.
Okay, thank you, Mr. Chair. We're seeking approval for going from the standard codes that are normally that you would hear in overhead in the hospital, things such as code silver, code black. We want to move to more of, for us, a code silver was a active shooter. So now what we would like to say, paging overhead, is actually the words active shooter. Instead of a code black, we would like to say a bomb threat. So that way people would know what that means. Different organizations use different colors for their different for the codes, and so there's no standardization, whereas with the plain language, there would be some standardization and people would know what to do and how to prepare themselves. So if I just said a code silver and there was an active shooter, nobody probably around the table would know what that meant. Other than the ones who know the codes, we would know to run and hide and lock ourselves away. So that's what we're seeking the board to approve us to use plain language versus different colors. Happy to answer any questions.
Dr. Martin, you recognize?
Will instructions follow? In other words, you announce active shooter. Will the patients, visitors know what to do?
That's the staff would know what to do, Dr. Martin. That's why we want to, because some of the staff may not know what that code silver is as well. They'd have to look at their badge, but they would know what to do because they're trained. Actually, coincidentally, we had active shooter training this week, and the staff has attended that, and so they would know what to do with the patients once that code is called. We're responsible for the patients. They would know what to do in those situations. So our job would be to move the patients out of harm's way and place them in a safe place.
I'm thinking more visitors who might be in a waiting room or cafeteria. Or
Same thing with those. With anyone that's in the facility, it would be up to us to manage that environment. So it would be no different if I called a code silver. I would have to manage that, and we would have to manage the facility and the environment until law enforcement arrived.
Are other facilities moving to a more plain language? And I guess, has there been an issue with kind of people going to more of a frenzy and having it be a negative effect rather than maybe a coordinated effect with staff? That would be my biggest concern with yelling active shooter, right? Or bomb threat.
Right. No, not from what I understand, most hospitals are going to plain language. So that way people are better informed and know what to do to get out of the harm's way, opposed to we're calling a color out. And if I worked at one facility, code brown may mean something different here at this facility. So it's easier for everyone to understand and get on the same page.
Thank you, Dr. Brown. We'll entertain a motion for approval.
So moved.
second.
Been moved and properly second. All in favor, vote by the sign of aye. All opposed? Ayes have it. Thank you. All right, our quality, but before we go to our quality report, I want to just take a point of personal privilege because the chief of staff from the mayor's office is in the room, and so I want to welcome
The chiefs of staff.
right, the chiefs of staff. Right, we have both, right? So thank you all for being here. And, all right, our quality report.
So, Mr. Chairman, if I may, I'm Kathy Phillips. I'm the Chief Performance Excellence Officer. And I wanted to let you know, Ms. Trudy Iams, who is our Director of Quality, is out ill, unfortunately. However, the quality dashboard would have been included in everyone's packet. And if you have any questions in regard to the information that was provided, I'll be more than happy to take those questions and make sure Ms. Iams has those addressed at the next board meeting.
Are we still needing to approve the quality report?
Yes, sir.
Okay.
If you don't have any questions. If you do, then we would defer it.
Good.
What is the anticipated date for the review being completed on quality of care and under acquired infections?
Any other questions?
You're going to get that answer for?
I'll have to get that answer. That correct?
Okay,
Correct.
all right.
I'm sorry.
I just
The
wanna make-
anticipated date, correct, for the review of the quality of care under the C section.
Okay. Any other questions? All right, we'll get.
I do want to reiterate, I know that Ms. Iams explained to you all last time that a lot of that data was lagged because it was being sent out. It is currently now in-house as of November 1st, so that will have more real-time data too as well. Thank you.
We were sent the dashboard, so we have the information. I think we can move forward with approval of the quality report. I'll entertain a motion.
So moved.
Second.
All right, it's been moved and proper second. All in favor, vote by the sign of aye. All opposed? Ayes have it. All right, we now have our contracts and capital expenditure requests. We'll start with A, information on the marketing and media relation RFP. Ms. Poole, you recognize?
Good evening, everyone. Okay, so one of the things that we realized we had to do is the original RFP had a date of intent to award contract of November 27th, with the board being November 30th. It did not allow the 10-day window in order for it to be published and for you to approve it at today's board meeting. We also have had a lot of work with IT and with the Cerner implementation. So what we had is a 3-person group. We had 3 RFPs that were submitted by the deadline. So 3 of us met to review those 3 RFPs to ensure they met the qualifications. They did. So then we moved forward with another team, which included members of the executive leadership team, as well as our directors over the Nashville Healthcare Center, the Nashville Diagnostic Imaging Center, which is also NGH Medical Imaging, and our School of Health Sciences as being the external arms of Nashville General Hospital. So that group actually interviewed all 3 RFP respondents. So from that, we are working and doing our due diligence on the technical pieces, making sure that they have things like no debarment issues, done numbers, things along those lines. And then now we are going through and working on the pricing. So I didn't want to rush it, and then we really couldn't with the 3-day window between the 28th, 29th, and then today being the 30th. So we will do December 15th as far as the 3 organizations have agreed. And then January 15th, we will do our intent to award, which will give the 10-day window for Janet to post everything available for open review, and then bring it to the January 25th board meeting for approval. Any questions?
Yes.
Yes.
So, Kathy, then on the 15th, when it's posted, the 3 will be posted, or the 1 will be posted?
The 1 will be posted. You'll get like a contract analysis with the recommendation that will be going to the finance committee that will eventually go to the board of these were this is what we did, and here's the analysis, and here is the recommendation.
And prior to the board meeting, the board will get a summary of the 3?
So prior to the board meeting, if you would like to request that or see that, we will have those available. That is open to the public.
I would like to see that
Okay.
prior to the board meeting, not the day of the board meeting.
Right. Everything will have to be available by January 15th
Okay. All right, thank you.
to meet that 10-day window.
All right, any more questions? All right, thank you.
Thank you.
We now have 2 contracts to consider. They both have been discussed in the Finance Committee as well. And Dr. Brown, you recognize on the Whalum Security contract.
Okay, Mr. Chair. Just a note of interest for the board, share with Dr. Martin. We did get a 6-month extension on the robot. So we will not be making payments until the 6-month expire. So I think Dr. Miller had questioned at the last board meeting, and I just wanted to give him an update that we did get that extension. So we won't be making payments on that. So the first contract I have is Welland Security. We've had G4S or Allied. It's changed names several times over the last 4 years since we moved from the Sheriff's Department. And so it did go out to RFP. Mr. Galoo did an RFP for this project, and we end up going with them. They're a little bit more expensive than the previous contract, and there's various reasons as to why that is a little bit more, costs a little bit more, and we talked about that in the Finance Committee. But it's a 3-year term, and it's for our security here on the campus. I don't know. And so we're a little bit different than most hospitals. Most of the other hospitals have their own law enforcement on the campus. We use a security firm that carries that are armed officers here on campus, and so that cost is a little bit more than if they were just standing and observing. So happy to answer any questions on that contract. Yes, sir.
So, Dr. Brown, there were 3 that responded to the RFP?
Yes, there was 3 that responded.
And was there a significant price difference in the 3?
I think we explained that in the last board meeting. The reason why the cost, no problem. We can go through that. One, the reason why it was a little bit low, cost a little bit more, Mr. Nelmore sort of explained that instead of having 21 or 22 officers full-time, they only provided 14. So if you sort of did the numbers and added up what they should have had here, it would have probably been like $100,000 less than what we're going with currently. The officers are better trained. They have a lot more training to offer, and so we're going to get a better quality officer than we had with the previous company.
But among the 3,
they were pretty much comfortable and within that range of how we felt which would be the best for the hospital.
Thank you.
You're welcome. Other questions?
Thank you, Dr. Brown. We discussed this in the Finance Committee in terms of, making sure that the officers that we get under this contract are quality, and a component of that is what we pay them. And so under this contract, and it's in there, the amount that we'll be paying them is a little bit more, but you get some folk that's going to show up, work the shifts, be here, be reliable, and so that's important. So thank you for the work you all did on that. I'll entertain a motion to approve this contract.
Is this going to be a different provider
Yes.
than before?
Yeah, we had Allied, right?
Yes, sir.
Yeah.
So moved.
Second.
All right, been moved and properly second. All in favor, vote by the sign of aye. All opposed, ayes have it. Thank you. We'll go to our next contract. Dr. Brown, you recognize?
Thank you, Mr. Chair. Agility Health Incorporated is a biomed agreement that we've had probably for the last 4 years. And so we decided to send it out to bid as well to have other people weigh in and see if they would be a better fit for us. In the end, we end up going with Agility. We cut out some of the components of that particular contract, which was the asset management, and we decided as a team to bring that part in-house. But as far as our biomed and our imaging equipment, Agility will be taking the lead on that equipment and repairs. So it's a 3-year contract, and like I said, it went out to bid. And so it's nothing different than what we had, other than we just sent it out for RFP as good stewards to see if there was another company that could do better.
All right, any questions or comments? This contract also was vetted in the Finance Committee. All right, I'll entertain a motion for approval.
So moved.
Second.
All right, it's been moved and properly second. All in favor, vote by the sign of aye.
Aye.
All opposed, ayes have it. This contract is adopted. Are we now ready for Dr. Williams? We have him. He's going to join us by phone, right? Okay. All right. Medical staff reports and bylaws and medical staff current bylaws. Dr. Williams, you're recognized.
Thank you, Mr. Chairman. Can you all hear me okay?
We can.
Okay, what I wanted to report is that last night we had a for the medical staff, and I'd say the general consensus was that the medical staff wanted one more week to have a deep dive into reviewing the draft document, and we have preliminarily scheduled a second town hall meeting next Wednesday to review the document. There weren't that many questions, so we'll have to see what sorts of questions emerge next week, but I felt pretty confident, and other medical staff leaders on the call felt confident we could have the vote in the month of December. So we'll have more concrete information after that town hall meeting next week. Let me pause for any questions.
All right. Thank you, Dr. Martin. We'll now hear the medical staff current bylaws, which does require approval.
Yes, so if the board will remember, we sent out information earlier this year due to a new joint commission change, which said that a medical staff reappointment could go as long as 36 months. We decided to go with that recommendation, and we changed our medical staff credentialing term from 24 to 36 months. Subsequent to making that change, we've heard some chatter on the medical staff airwaves and through the National Association of Medical Staff Professionals that CMS has language in their conditions of participation that says surgeons should have their information evaluated every 24 months. It's a little bit vague, but our medical staff and really our quality staff and the folks in the medical staff office really felt like we didn't want to, I guess, be the first movers on this. And we've also heard that hospitals have been surveyed by CMS for going to 3 years. And so the medical staff voted, the MEC voted to make a recommendation to the board that we go back to 24 months until there is more clarity and more continuity between the Joint Commission and CMS. So tonight we are asking the board to consider our recommendation and vote to support going back to a medical staff credentialing term of 24 months. Let me pause for any questions. I think in your documents I've given you the CMS language and given you the Joint Commission language in case you want a little bit more details, but I can also articulate that better if need be.
Hello, this is Brian Fisher here. I was wondering, do you think this coincides with the new maintenance of certification that American Board of Surgery is doing? I know I just completed mine. It's now moved from, it used to be a 10-year test, and now it's every 2 years. And it's a kind of continuous process. Are we going to make that, is the idea to align it with that maintenance of certification for the surgeons?
Did you hear that, Dr. Williams?
Dr. Fisher, I don't want to sound crass, but I don't think these organizations are that coordinated. So I don't think it would be consistent with that. I think that's probably a separate move, since the board certifications are monitored by the specialty boards and completely independent of CMS and Joint Commission. I suspect that CMS will eventually align with Joint Commission as they've done in the past. They've tried to be the same, since Joint Commission has the deeming ability to have a deemed status. So if you're Joint Commission accredited, you're automatically CMS accredited. So it doesn't make sense for those two organizations to have two different standards. So I suspect that CMS will subsequently change, but we just didn't want to put ourselves at risk for a survey.
Okay, thank you.
Thank you.
Thank you, Dr. Williams. We'll entertain a motion.
Move approval.
Second.
Been moved and proper second. All in favor, vote by the sign of aye. All opposed, ayes have it. We'll now have our financial report. Bruce, you're recognized.
Okay, good evening. I guess we don't have it up. They've got it in their packets. Okay. Month of September financials for the hospital. It was not as good as the first 2 months, but still a positive margin for the month. So we made a little money in the third straight month. Just statistics-wise, our inpatient admissions were 207, about 20% above the budgeted level. But I would say that what stands out sort of in these stats is our observation visits and our observation hours and days plummeted about 45%. And that relates to some efforts being made in UM and case management to conclude on patients when they're in that first 24 to 36 hours of their stay here in a bed. And that has helped us get more of those patients committed to an inpatient meeting criteria, and similarly has committed our hospitalists and other physicians to getting patients discharged more quickly than sitting in an observation status where reimbursement is poorer. And, if you're really not sick enough to be in a hospital, you probably shouldn't be in a hospital. So honestly, even though the numbers look a little bit askew because July we had 202 observation admits, August we had 192, September we had 132. So it's dropped significantly. Our observation days have dropped from 300 to 165 this month. And so it has just an impact in a lot of areas, and we'll talk a little bit about that on the income statement itself. But if you look through the numbers, our emergency department was down a little bit, about 5% this month from budget and from the prior month. And year to date, our emergency visits are down 5% from a year ago, but a year ago they were up 5%. So we talked a little bit in finance of whether that indicates anything. I mean, it's not a trend. We were up 5 last year. We're down 5 through the first 3 months of this year. So steady, but not growth at this point. ED admissions were actually up at 172, so well above budget for the month. Our clinic visits were down this month, dropped from almost 800 or 700 visits this month. We had two surgeons who were out on FEMLA in September, and that affected both clinic visits, also affected surgeries, outpatient surgeries in the month, you'll see. So for the month, we had 35 inpatient surgeries, which was right on the budgeted number, a little ahead of last month. But outpatient procedures dropped from 110 to 90. Those two physicians being out certainly had an impact. One is a very busy outpatient surgeon. Cath lab was up significantly last month. Deliveries were down. Our deliveries are like, hemlines in the stock market. They have been as high as the 50s. And this has been a very low month, September 24. So those are just sort of the rough numbers. Case mix was a little up this month, 1.44. That measures acuity of patients in the inpatient beds. And then, so if there are any questions, I'd be happy to answer them. We did cover this briefly in finance today. So on the income statement side, our gross revenues were about 12% below the budget. And as you heard, our days were about 12% below budget. Our clinics were low. The emergency department was a little low. And our observation days were down significantly. Those are the big impacts why our outpatient revenue fell 12% short of budget. With a $3 million miss in gross revenue, we had a $1.1 million miss in net revenue. Bad debt was pretty high. We had a lot of uninsured patients in beds in September, so that flows through. So we collected we expect $3.9 million of patient net revenues, but it was well short of our budget. The savior, again, for the hospital for the month was our essential access dollars were still well above budget, almost $2 million above. That relates to the supplemental pool and from the state that came in much higher than expected in July. And so we're feathering that through the income statement. There was a question about whether we can expect that to continue all fiscal year. We can't. The state has a different fiscal year than the hospital, and they will reset 10/1. And those payments usually come a few 60 days to 90 days after. I would keep my fingers crossed that we could maintain this level of essential access dollars, but it's unlikely. And unfortunately, they don't share the algorithm with the hospitals. So we're happy to get it, but I don't think we can count on it going forward. For the expense side of the equation, we're about $400,000 over budget for the month. The areas that stood out were pharmacy and supply, and they're on budget or better for the year to date. So I think those are just unique. Our pharmacy numbers are driven a lot. I see our oncologist is here in the room, and even though it's a relatively small department, it's a big piece of our pharmacy spend because the agents that we use to treat patients in those spaces can be pretty expensive. So that's typically what we see. I look for a 3-to-1 charges versus what my expense is, because that tells me we're charging for this the pharmacy supplies, and that met the threshold this month. So we think the expense is relative to the revenue that was produced. So all in for the month, we had a nearly $300,000 positive margin. We were expected to lose about $200,000. And then for the year to date through the first quarter, we have about a $3.3 million profit, way better than our budget was and well ahead of where we were last year. So that's our September financial statement, Mr. Chairman.
Thank you, Bruce. Questions, comments?
Bruce, how many staffed beds do we have in-house?
That's like a trick question, Dr. Miller. Honestly, we staff the hospital typically for about 65 beds. Now, since I've been here, and Dr. Webb's been here a lot longer than me, we have hit 80, low 80s a couple of times during COVID. Mm-hmm. But the women's floor is probably the least utilized, and the 7th floor, which is the incarcerated floor. Those are probably the two that have, that we have 16 beds on the 7th floor. They may average 5. Right. On the 4th floor, that number just goes up and down depending on deliveries and postpartum and babies, but we have to keep minimum staffing on that 4th floor. And so we talked at finance. I said we could probably cover 120 deliveries with the staff that we have, but we have to maintain minimum staffing to maintain the program. So, but Veronica and I would tell you, we think we're around 65 to 70 staff beds typically.
And the average census is what?
It's probably about 45 to 48. And Dr. Miller, we do, every day, and we have nurse directors in the room with us, we run census multiple times a day, and they flex nurses off if the census doesn't support it, so.
And then for contract nurses, has that dropped some? I know that we got some nursing service to help with staffing, but of the number of, say, travel nurses, has that dropped off?
It's steady. I wouldn't say it's dropped off. It's steady. It has not improved greatly. Yeah. We're hiring. We have probably hired 7 or 10 in the last 60 days, but it feels to me like if I hire 7 or 10 new, we may lose 5 or 7 over that same time frame. Yeah. And I think Veronica and Chris Jett, who's our director of nursing, they would tell you that this is what we're still all sort of experiencing. It's not peculiar to Nashville General.
No, it's not. And then didn't we contract with a staffing firm to try and reduce the number of travel nurses?
Yeah, it's a recruiting firm that does, I think they have 3 full-time recruiters that work just for this hospital. I think 2 of them work in clinical and 1 works in non-clinical. And they've had some success, but I wouldn't say that we've got a lot of traction yet. And the challenge is we have to keep the people we've got, right? They can recruit them all day, but we've got to make sure it's an attractive place for them to work.
But have they been a source for a lot of the nurses that we've hired?
I would have to defer to our nurse director back there. I don't know. Chris,
Because,
do you know?
Yeah. What do we pay? We're paying what for that service?
Yeah, we're paying about, it's about $13,000 per recruiter FTE. So per month per those 3 positions. And
So we're paying
almost 40,000.
40,000. Well, yeah, 40,000. So I guess at some point we need to review that because especially when we need to account for whether, I understand the turnover, and that's common to all institutions.
Mm-hmm.
But if they're not responsible for a lot of that was kind of the hope is that we contract with them. We're going to reduce the number of traveling nurses.
Yep. It is.
And if that's not the case, we probably need to review that contract at some point.
Just one more point, Dr. Miller, just because we used to have our own nurse recruiter, and so we don't have to pay that position anymore. So it's really like a net of 2, but I agree with you that we have to look to see if they're making a dent in the issue for us. Any other questions?
And how long has that system been in place? I remember the discussion, but I can't remember how.
4 or 5 months. I think it's about 4 or 5 months. I don't think they've not hit the 6-month mark yet. So, Chris has given me this 4.
4 months. Okay.
Yeah.
Thank you.
So just to follow up, who's making the determination on our return on investment on that particular contract? Who would that fall under?
Well, I mean, Diana, it was like the executive sponsor that brought human to the group and so forth, but we've all participated in it, and we have roles in making sure that they get everything they need. They're like the big net that throws the big net out there, and then they bring them in, and then we have to meet them, obviously, and accept them. I do say the challenge for us is also keeping the folks that we have working here, because even if they do a great job, if I lose 10 or 12 a month, or we do, and they cover non-ancillary, so I've used them a little bit, and I thought pretty good for my purposes, but I'm not out there fighting for nurses who can walk across the street. I'm looking for accountants and revenue cycle people.
But I think that, as a hospital, we should do everything we can to retain staff, and that's a challenge. But if we're paying for a service that is not bringing in the new people that we're hiring, then I think we need to look at whether it's better than what we had.
I agree with you, absolutely.
So, quick question. Often hospital systems will have, they will have a relationship with nursing schools, and do we have a relationship with any nursing schools? Do we do teaching here? Like that's often a great conduit for getting nurses. They have an experience at the hospital, and they choose to stay here.
Yes, we do.
Okay.
I would also say that firm works across the board. It's not just nursing. There have been a number of positions filled that are non-nursing, and some of them would have required agency or going through agency, so you avoid having to pay those premium dollars. So we'll assess it at a 6-month period, and then we'll make a decision on it.
Okay, fair enough. Bruce, did you have anything else on the September financial?
That's it. Thank you.
Any other questions? All right, we need to approve the September financials. I'll entertain a motion at this time.
Motion to approve.
Second.
All right, it's been moved and properly second. All in favor, vote by the sign of aye. All opposed, ayes have it. Thank you. All right, Dr. Webb, you're recognized for the CEO report.
Thank you, Mr. Chair. Just a few announcements and updates I want to share with the group. Today, we held a blood drive, Red Cross blood drive, and on December 2nd at 9 a.m., we're going to be hosting our alumni group from Friends in General. These are a group of retirees from the hospital that have stuck with us, and periodically they come in and host and invite guests in to meet with them and share their concerns and thoughts. So you're welcome to join and see some of the individuals that have worked with Nashville General Hospital over the years and have retired. Upcoming on Wednesday, December 20th, 3 p.m., we'll be hosting our Secret Santa in collaboration with the foundation. This is a program that historically, if you remember, Reverend Fuzz has led this effort, and I'm sure he'll be in the building at that time. It will be pictures with Santa, and is this breakfast? Okay, no breakfast. Okay, so you're going to 3 p.m. Okay. So no breakfast, but there will be pictures with the children. There's over 50 children, and just so you know, you can be a Secret Santa by selecting one of the, do we have the names outside in the lobby? So we need to make sure that the names are outside. Okay. So, you can purchase a book, a toy, jacket, outfit, shoes. These are typically the things that the kids will need. So if you are a Secret Santa, those are kind of a cheat sheet on what you can purchase for the children. I want to give kudos to our own Melanie Thomas. She participated as a panelist for the Black Leaders in Technologies November event highlighting women in tech. Our own Josh Baxter, CRNA, was named 40 Fast and Future Leaders of Surgical Services by Whitman Partners. And on November 8th, we'll be, we did host the STEM Goes Red experience. This is where teen girls were mentored by some of our staff here, our own Dr. Fahey and Dr. Muckle. Two of our physicians participated, so kudos to them. And that's all I have with updates and announcements. Happy to answer any questions. Thank you, Mr. Chair.
Thank you, Dr. Webb, for your report. Let's see here. Oh, my report. The one thing I want to make sure we do get moving on is several of the committees. We need to stand some of those up. And Dr. Martin was very kind. He sent me a blueprint in terms of those committees and some recommendations in terms of in serving. So I will be reaching out to you individually, and by our next meeting, we'll have some recommendations for this board to consider in terms of some committee appointments. For instance, we're behind in the CEO evaluation, and we need a team to lead that. So that's one committee. If you're interested, certainly let me know. I've asked Ms. Christina Smith if she would be willing to take the lead and serve as our chair of our finance committee. And she, with her background, I mean, it just speaks volume, and we're lucky to have her. And she has agreed to serve in that role. So that would be my recommendation to this board. Now, I don't know, do we have to post that and vote on that next time, or a committee appointment?
Since the state has been closely monitoring things. It's showing green. I guess I just didn't speak towards it. Yeah, I would recommend that.
Okay, we'll add that to the agenda for the next meeting.
Are the committee meetings, they have to be open, non-virtual? Are they virtual, non-virtual, all in person?
In person, yes, and they are open.
Okay.
So speaking of meetings, we had thought about not having a meeting in December, but apparently there's an important contract that the CEO made me aware of that we need to address, and so we will need to come back for a meeting in December, and we expect it really will be a one-item agenda, and we need 6 people to be here at least so that we can, in terms of executing that contract, we need to do it in a timely manner, and so we will need a December meeting to be able to meet the January deadline, from what I understand. And so we've got a couple of dates, and if this works, just let me know now. December 18th and December the 20th are 2 dates that we are looking at. Does either of them feel better? Yes, I'm sorry.
Same time?
Yes, same time, yes.
Which contract is it that we're approving?
It's the Cerner electronic health record contract.
And the contract will be sent out to you prior to the meeting.
Well, we need a finance committee prior.
Yes. Do the 18th feel good? Okay. Yeah, I'm saying the 18th if I can get enough thumbs up. I see 5 so far, 6, 7, 8. Oh, we're good. Let's roll. All right, so the 18th.
Dr. Webb, have we not approved Cerner as our vendor? Or?
As a vendor, yes. This is a specific amount included in the contract that the board would need to approve. And the reason that you're doing it in a special meeting is because it needs to be done within a certain, and so the January date would be pushing forward the timeline for completion. So in order to get it completed on time, we would need to get the final, and this information has just been really pulled together as we've looked and discussed with them at the number of items that needs to be, or the features that need to go with the EHR. So the final features would be captured in this cost. Is that accurate, Melanie? Well, never mind. If it's not, don't say it. We'll discuss it later.
Come to the mic.
This contract is for infrastructure that the Cerner platform will run on, mostly back end. The last time we did a network refresh was about 6 years ago, and the typical life cycle of our network equipment is 4 to 5 years. So we're past that and coming to end of life with most, if not all, of our equipment.
Thank you. So we will, yes.
Can I just ask for clarity? You said both Finance Committee and the board, so do you want that at 3 o'clock and 4 o'clock, or 3:30 and 4? How would you like that?
What works better for the Finance Committee? 3:30?
3:30 and 4.
3:30 and 4?
3:30 and 4?
Yes, just for one item.
Yes, thank you.
Is it possible to have a combined meeting of the board and the finance committee?
I'm looking at legal.
I mean, they each need to be separately noticed and convened separately, but any board member is always able to attend any committee meeting. You just can't participate as a board member in a committee's actual meeting, but you're welcome to attend and listen. And I suppose you could sign up for public comment, but since committees take no action, you probably aren't going to be recognized.
Since this is a decision on behalf of the board, wouldn't this be something that the board could meet on and make a decision and not have to have 2 separate meetings?
Yeah, it's just been our policy that we were running those contracts through the Finance Committee first.
Right.
And so I would rather us not change that.
Okay.
Speaking of public comment, I do want us to, so I want to share this with the board, that I want us to observe what we've written as part of our policy, that we allow for public comment and that we have a time frame. And so you know, we want to hear from individuals, but we want to make sure that everybody respects this space and respect what we're doing here, and so I will be firm but polite in our 3-minute expectation, and so when we move forward, you'll see that, right? Okay. Also, I want to just say thank you for the vote of confidence to serve in this role. It got a lot of media attention. Got a text message from the mayor of the city, which was pretty exciting. My 10-year-old son said, "Dad, I think I want a raise in my allowance." I said, "Why?" He said, "Because you're now over the hospital. And that does not pay." My finances have not changed, right? So again, thank you, and we're excited about the important things we have moving forward. I do have, as Dr. Webb indicated, we are planning to meet with the mayor's office. Both of us will meet with him. I will also be meeting with Dr. Hildred at Meharry by his invitation. So he reached out to me and asked if we could have a conversation, and so I certainly want to do that as well. So that concludes all that I have. If there's nothing else, yes, sir.
Mr. Chairman, as you know, I've been here for about 6 months, so I'm an expert on all things associated with Nashville General Hospital. And it just strikes me that we spend a lot of time talking about revenue, which is appropriate. We spend a lot of time talking about where the money's coming from, which is appropriate. And I kind of pancake that over to what our role is in the community. And it seems to me, again, being such an expert on healthcare, that it's not, one side of this is about the revenue and making sure that we have appropriate revenue, that we have people coming in that are paying for the services. But there seems to be another side of the ledger, which I'm pleased to know that there are efforts here at the hospital, and that's about wellness programs and about doing things to educate our community and encourage our community, particularly our community that we serve, to encourage wellness, which on the one hand would maybe prevent them from having to utilize the services, but on the other hand would raise the level of health in our community, which to me seems like a pretty good thing. I think there are significant efforts here in that regard. I've experienced some of them through some of the tours that I've had, and it's really terrific. But I'm frustrated a little bit as to how we can have, with all of the limitations that we have for statutes and legal reasons, to have discussions about how we can encourage more and develop more of these kinds of programs to utilize the resources and experiences of board members who might be able to contribute some things that maybe aren't necessarily experienced within the healthcare community, but could offer some additional opportunities. One thing really strikes me, and Dr. Webb, you mentioned about the Secret Santa, and this is a very small issue. Is the foundation involved with the Secret Santa effort?
Yes, that's where it began.
Great, because if somebody is here from the foundation, I hope they might be recognized. I have asked before that we invite somebody from the foundation to come here and give us a report about finances, about what programs they're doing, about what we can do to support the foundation, which is supposed to be supporting the hospital and its efforts. I'd be happy to make a contribution to the foundation if I knew more about it. I hope we can, and I don't know what the next step would be, to have further conversation. We tend at these board meetings to deal with agenda items, and that's appropriate, and it's certainly what we need to be doing. But how can we create an opportunity, an initiative, where we can talk about how to support Dr. Webb and the staff and how to discuss issues of policy, not the specifics of contracts, not the specifics of bed utilization, but the broader issues of how we best serve this community in support of the team here at the hospital.
Yeah, thank you for sharing that. And we used to, I don't know, it's been a while, but we used to have 100% gift giving to the foundation of all board members. And I don't know if that just went away, but I mean, I remember an envelope being put in front of me, and it just made us feel a little bit a part of that process. So I don't know if, is somebody here from the foundation?
Well, just so you know, the foundation executive director did retire, and we have an interim individual in place. I've met with the board chair of the foundation, and we're collectively searching now for an executive director for that role. So, but we can have the interim leader of the foundation come to the next board meeting and update, share some information, as well as how certainly would be happy to gain access to your contributions as well. That is certainly something that the staff in the hospital do as well through payroll deduct. So.
And to your point, Mr. Lesser, there are some things that we are obligated to deal with in terms of the agenda, but I'm very open to whatever agenda items or ideas you all suspect we need to address to be added. So I'm very flexible in that. So absolutely.
I feel, Mr. Chairman, that sometimes we're constrained by statutes and other things about what we can talk about, what we can't talk about. And if there's any opportunity that you can offer to us, council, it would be great.
Yeah, I mean, the way this is typically done is just like you're doing it. You're bringing up an issue to be addressed. No one would likely be prepared unless it was by accident to address what you're bringing up as an item you'd like to see or receive input on. The chair has the ability to set the agenda, so you can make a request at this meeting, and then the chair for the next meeting, not the special called meeting, but a regular meeting, can add an agenda item, because it sounds like you're seeking a report, and whether or not that would ultimately lead to an action item. I'd counsel you further about how to get that on the agenda, but board requests, sometimes that can be a placeholder on an agenda where it just has everyone thinking at that moment, I want to receive information either from staff members or outside, or talk about policies. That's an opportunity for it to be placed on the next agenda for an action item if it's needed yet, or if it's just simply a report to get the information you're seeking.
Mr. Chairman, is the December meeting a special call meeting, or is it a monthly meeting?
It's a special called meeting because it's not in the regularly scheduled last Thursday of the month, so it has to be a special call.
So, I mean, there can be no other item on the agenda?
No, we can have other items on the agenda.
Yeah. Well, I would just suggest we, if possible, we accelerate the committee appointments so we can have the committees start to meet in January. And I would also request that Janet come up with a calendar for us that we've talked about before, for when we have elections, when we do a CEO evaluation, and anything else that has, a timeliness factor to it and that needs to be dealt with the committees, because as it's been pointed out, we don't always get to those things in a timely fashion.
Duly noted. We will add the committee appointments to the December agenda, which, by the way, shouldn't add much more time to the agenda. All right, anything else come before us? All right, a motion to adjourn? Second, we are adjourned.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.